Hi, this is Shanshan Wang, a research fellow at the Global Center for Integrated Colorectal Surgery and IBD and Intervention Endoscopy at Columbia University Emory Medical Center. We are presenting a case involving a 46-year-old man with an ileal pouch and underlying ulcerative colitis, who came to us with dyspepsia, fatigue, and anemia. His pouch-related history included a prior episode of small bowel obstruction, although no clear stricture was seen on follow-up MRE. He also had an anal pouch stricture that had been treated endoscopically in the past. Initial evaluation with labs, EGD, and pouchoscopy was consistent when ACE-induced gastropathy, enteritis, and pouchitis, as he had taken NSAID for several weeks before his symptoms began. However, his anemia persisted over the next 3 months despite multiple iron effusions. To further investigate the source, a video capsule endoscopy was performed, but the capsule became retained in the bowel. In the first pouchoscopy, the gastroscope was advanced 70 centimeters from the anus, but the retained capsule was not identified. A repeat pouchoscopy using a slim colonoscope revealed 2 strictures at the stoma closure site. Endoscopic stricture therapy, including endoscopic strictureplasty and balloon dilation, was performed on both strictures. Despite this, the capsule still did not pass spontaneously. A third pouchoscopy, this time using an endoscope via anus, allowed for the successful retrieval of the capsule with a Rosnet. We'd like to highlight the importance of reaching the stoma closure site in the pre-pouch ileum, as this location is frequently narrowed due to ischemia or anastomotic tension after surgery. Accurate characterization of pouch structural disorders often requires both endoscopic and radiologic evaluation. However, even MRE may fail to detect the stricture, particularly during asymptomatic periods, as demonstrated in this case. This patient presented the unusual feature of a high stoma closure site, located 50 cm above the pouch, which required a slim colonoscope for adequate endoscopic diagnosis and treatment of the stricture. This case raises the question of using a patency capsule in patients with ileal pouches. A patency capsule, which is a dissolvable capsule mimicking the actual device, is often used to assess if a capsule endoscopy can be performed safely in patients with suspected stenosis in IBD. Although its roles in ileal pouch patients remains unclear. In our case, a patency capsule was not used because of a recent MRI showed no evidence of small bowel stricture, and any capsule retention at the anal stricture could have been managed endoscopically. For future patients, a patency capsule may be beneficial for those with a history of obstruction or stricture, or when radiologic imaging is not available.